our patient with metastatic kidney cancer presenting to his spine, having his kidney removed, and then developing lung metastasis. This is a fairly kind of classic, if you will, presentation of an intermediate risk patient. The disease burden is increasing, although the burden isn't severe. He had some symptoms, although they were manageable with radiation. The question then comes, how are we going to manage this patient? For the last few years, we've been conducting studies in the frontline space looking at combinations or single agent therapies compared to sunitinib. Sunitinib has been our standard of care, along with pazopanib, for frontline metastatic kidney cancer. And one of those studies was the CABOSUN study, one that I was involved in, ran through our cooperative group, the Alliance Cooperative Group, was a 152-patient randomized study of cabozantinib versus sunitinib, open label, intermediate and poor risk by the IMDC criteria, so the same criteria we talk about with things like performance status and anemia and thrombocytosis and lymphocytosis. These are the factors that help us define these intermediate risk and high risk patients. That's who we focused on for CABOSUN. And we did that for two reasons. One, because that's where sunitinib is probably coming up a little bit short. Historically, we've known patients with good risk features do really well on TKIs. That's going to be hard to improve upon. But the intermediate poor risk is where these patients have had accelerated time to progression, historically somewhere around 5 or 6 months for that group. So we studied that population in a cooperative group setting. These are largely community centers around the country. So in many respects, this is a real-world study. This is different than maybe many of the industry-sponsored studies run at top academic centers in Europe and maybe here some in the US. This is a strictly US community population that was really looking at the real-life patients you're going to see in your community with kidney cancer and randomized to these two oral agents. Cabozantinib was given 60 milligrams daily. Sunitinib, the traditional 50 milligrams daily, 4 weeks on, 2 weeks off. Patients were treated until disease progression or unacceptable toxicity. And the results were clear. By our investigator assessments, we saw about an 8-month median progression-free survival for cabozantinib and 5.3 months or 5.6 months for sunitinib. These results also suggested a big difference in the overall response rates, with a 33% objective response rate for cabozantinib versus just 12% for sunitinib. Well, the study was significant. Finding was published, and I think because of the frontline status, because cabozantinib was already approved in the second-line status, was taken to the FDA. An independent radiographic committee re-reviewed the data, and it came out very similar. We see again this sort of 8-month versus 5.3-month difference in the median progression-free survival between the arms. And we saw actually a little bit more strict criteria for objective response and confirmed response, lowering both arms down to 20% objective response for cabozantinib, just 9% for sunitinib. But really, again, showing this sort of double response rate, this almost doubling of progression-free survival, a really, I think, clinically and statistically significant difference between these two arms. So for me, getting back to our case, this is exactly how, for TKIs now, we want to treat patients who have these sort of intermediate and poor risk features. And to me, cabozantinib is a new standard of care for that population.